I'm going to talk to you about paper 1 in the series, which is looking at midwifery and quality care, findings from a new evidence-informed framework for maternal and newborn care. These are the co-authors of the paper. I think those of you who are in the room and many listening online, I hope will be able to access the paper and maybe follow through as we're talking this morning to have a look in more detail. The ones with the stars are the ones in the room. So just to note that anybody who's got a little asterisk, you can go and cobble them over lunch and have a chat about how it was done. But just to note that actually with paper 1, particularly because it was setting, if you like, the core framework for the series, that it was agreed by all the series authors and consensus developed with a range of organisations. The problem that we had in our scope, the lens that we brought to the problem that we wanted to tackle in paper 1 is unacceptable rates of mortality and morbidity globally. I don't have to tell this audience the detail of that, but you will find it in the paper. Very high rates of unnecessary interventions, not only in high-income countries, but increasingly also in low-income, and I think we're all very familiar with the escalating rates in middle-income countries. Inequalities in care and outcomes. Longer-term psychosocial cost-effectiveness outcomes often overlooked. Disrespect and abuse of women within the health system, and a wide range of health system responses to these problems, which people have been trying to tackle for many years, which involve a focus on emergency care, on developing facility birth, on specific tasks and interventions that will save lives, and on a diverse workforce and a diverse implementation of midwifery, which I've just mentioned and described. And that was the landscape, if you like, into which we tried to examine comprehensively and systematically the contribution that midwifery can make to the quality of care of women and infants globally, and the role of midwives and others in providing that care. I'm going to give you very brief methods from paper 1. You can read it in detail. There's a whole rather complicated diagram because it involved a multi-method step-by-step approach outlined in figures 1 and 3 in the paper. What we did was we defined midwifery and mapped its scope. We needed a stable basis for the examination of the evidence, because if you read writings about midwifery and if you read papers, it's often differently implemented in different contexts. We needed a stable basis, and particularly we needed to develop a framework for the care needed by childbearing women and infants that identified and distinguished between what care they get, how that care is given, and who provides it. That acted as our stable basis and onwards as a foundation for the series. We then used that framework to analyse practices within the scope of midwifery and to identify outcomes improved by midwifery. And you'll find, if you go online, a very long appendix that's very detailed with every single analysis that we did is in there. The sources of evidence briefly, 3 reviews of reviews, all very systematically done, of women's views and experiences, of effective practices and of care providers. You can see there the number of reviews that we looked at and the number of studies involved in that. I have to say that particularly the Cochrane Library, as ever, was a significant source of knowledge and inspiration, and we analysed 461 of their reviews of practices, thanks predominantly to the pregnancy and childbirth group, who are incredibly productive. We did 3 case studies of middle-income countries in transition, and we mapped the ICM competencies of the midwife to our framework. This is the definition of midwifery that we evolved and developed, and may I tell you, each single word is sculpted and considered and debated and undone and redone. So we hope it might be fit for purpose, at least for a while. Midwifery is skilled, knowledgeable and compassionate care for childbearing women, newborn infants and families across the continuum from pre-pregnancy, pregnancy, birth, postpartum and the early weeks of life. Core characteristics include optimising normal biological, psychological, social and cultural processes of reproduction and early life, timely prevention and management of complications, consultation with and referral to other services, respecting women's individual circumstances and views, working in partnership with women to strengthen women's own capabilities to care for themselves and their families. We took, and I've now put in red, some of the core characteristics in that definition, and we applied them and analysed them throughout those reviews that I've mentioned. So, for example, we applied that lens to the Cochrane reviews of pregnancy and childbirth to see which of them related to those core characteristics. This is the framework. This is a framework for quality maternal and newborn care. You might hear series co-authors speaking fondly and affectionately of it as the QMNC framework. It's in your pack and visible online. And I'm going to describe it to you very briefly, but it does bear some thinking about. I'm going to start at the top and work my way down. And it's starting at the top that is really interesting to start with. The green bar says for all childbearing women and infants. That means all childbearing women and infants. That doesn't mean low-risk childbearing women and infants. That means all childbearing women and infants. The pink bar is extra and additional care for childbearing women and infants with complications, but it doesn't mean they stop getting the other care. They don't transfer from one to the other. They keep getting that. So the next line down is the practice categories, what you might call interventions, specific things, the what is done. And the first box there is education, information and health promotion practices, assessment, screening and care planning practices, promotion of normal processes and prevention of complications. So at this point, the work that's being done is keeping people normal, preventing complications, supporting women to help themselves as well. And then moving in to the first line management of complications, into medical obstetric and neonatal services for more serious complications. In the online appendix and in one of the tables in your paper, you will find the specific and detailed practices populating all of those boxes. We then move down to the how, the organisation of care, the available, accessible, acceptable, good quality services, ideally with adequate resources, of course, with a competent workforce. And this is with continuity and services integrated across the community and facilities. It's done with a set of values: respect, communication, community knowledge and understanding, and care tailored to women's circumstances and needs. With a particular philosophy that's about optimising biological, psychological, social and cultural processes, strengthening women's capabilities, using expectant management and interventions when indicated. And then care providers, the characteristics of them, practitioners who combine clinical knowledge and skills with interpersonal and cultural competence, with a division of roles and responsibilities based on need and competencies and resources. Interdisciplinary working is built into this framework. I could talk about this. We could all talk about this framework for the rest of the day. In fact, we will be. You'll be finding it in every other presentation. What I will say is we then, with some trepidation, mapped out the scope of midwifery on the framework. Again, you can imagine the discussions. And what we've done is we've scoped in those first 4 top boxes, but with a dotted line around them, because in different settings with different skill mix, there will be overlap of roles and it will move. But basically that's what we've counted as the scope of practices. The horizontal lines, whoever you were mapping on this, if you were mapping obstetrics on here, if you were mapping community health workers on here, we would want all the 4 horizontal boxes actually included in for everybody. There would be a division among the practices. I'm going to scoot along here because I don't have very much time left. As we looked at these, we found 72 effective practices within the scope of midwifery, 14 ineffective. Those actually were things that have mostly been abandoned in some countries in routine use, like routine episiotomy or routine early amniotomy. The only practices that actually went right across the continuum were midwife-led care and community-based packages of care. The others were very fragmented. We found that 62% of the practices supported optimising normal processes, whether that was getting women to move about in labour, whether that was nutritional advice, whether that was breastfeeding support. It was about optimising normal processes. We found 56 outcomes improved by midwifery, as we've defined it and as analysed through the framework. Maternal and newborn mortality and fetal loss are reduced. First deliberate mistake of the morning, you'll find there's a couple of these missed out of one of the tables in paper 1. It's going right back in the online version. Never fear. I'm just telling you that in case there's eagle-eyed people telling me I'm wrong. These are the outcomes improved by midwifery. I'm not going to dwell on them. You can read them at your leisure. My point is they go right across the spectrum: mortality, morbidity, well-being, organisational outcomes, resource saving, psychological outcomes, improved mother-baby interaction. We then did workforce reviews, the million-dollar question: who should be providing midwifery? We found in 7 reviews 15 RCTs of care led by midwives versus others, and 109 RCTs, which is an interesting issue to consider, of care by community health workers, TBAs, versus no care. And we found, and this is leaning heavily on the results of the Sandel et al. Review, and Jane Sandel is in the room and is a co-author of one of our papers, midwife-led continuity models resulted in a range of positive outcomes, including cost effectiveness, and that was with women in the control group receiving care by midwives at the same time, just a bit less of it in a different organisation. Few benefits from relying on less skilled health workers. We then mapped the international competencies of the midwife from the ICM across all the categories of the framework, and in fact what we found was they mapped exactly to that framework full scope of practice. We then looked at case studies of Brazil, China and India to illustrate the consequences of economic development without the balancing effects of midwives, escalating interventions and inequalities in care provision, and you'll hear more about that from Mary Elena this afternoon, I know. Our key findings from paper 1. The framework can be used and tested in a range of contexts. You can use it for health system planning, you can use it for planning a curriculum, you can use it for monitoring and assessment, and a whole range of other outcomes. Midwifery has a particular contribution to make in preventive and supportive care, in preventing complications, in promoting positive outcomes, as well as preventing adverse outcomes for both women and infants. And midwifery is associated with more positive outcomes and cost savings when provided by midwives who are educated, trained, regulated, integrated in the health system with effective teamwork. And that's a really important statement: integrated in the health system. We will be coming back to that. These findings, we believe, support a system-level shift from fragmented maternal and newborn care, focused on identification and treatment of pathology, to skilled care for all. Midwifery is pivotal to this approach. Thank you very much.